Hi, everyone. Welcome to our presentation. And my name is Dr. Barry Sarvet, and my colleague, Dr. Michael Tang, is with me today, and he will introduce himself when it's his portion of the time. But I am a child psychiatrist, a child and adolescent psychiatrist, and I work at UMass Chan Medical School, Bay State. And I've also been involved in collaborative care for many years, and I was the one who helped to get the Massachusetts Child Psychiatry Access Program started back in 2004. And we're really pleased to talk about this topic today. We're going to talk about where we are in the series just for a moment. As you may have already heard, this is a six-session virtual fora session or program that's trying to cover different aspects of collaborative care and understanding kind of the work that folks are doing around the country and how you can be part of it, how you can be involved. And so you can see that there's a whole series of topics, and this is topic number 3. It really is focused on cultivating the relationship. We believe that relationship between ourselves and the folks that we're working with in primary care are kind of the heart, of doing collaborative care well. And we believe that it's really important in order to cultivate a good relationship to really understand who you're working with and understand their perspective and some of their needs and some of the unique attributes of their settings and things like that, so that we can really adapt, to working with them. So today we're going to be covering these 4 aspects of our topic. The first is Dr. Tang is going to be describing sort of different attributes of the primary care setting in pediatrics that are unique, or they're not unique necessarily, but they're different and unique to us because they're very different from what we usually live with, as child and adolescent psychiatrists. We're going to talk about, what the pediatric primary care providers need in terms of their learning needs, because these programs that we work in, a huge part of it, if not, the whole thing, is all about education and practical clinical education. Then we're going to talk about the way that primary care practices are increasingly part of networks, and we're going to tell you about how those networks work and why they're important, and also how they're paid, which actually influences a lot of the behavior and some of the priorities, of their practices, which we need to understand. And then lastly, we're going to talk about how to really kind of develop engaged relationships with these practices and some of the strategies to kind of progressively, make those relationships more meaningful and to really deepen them. So I'm going to hand off to Dr. Michael Tang for the first couple of these objectives.
Thank you so much, Dr. Sarvet, for having me here today and a chance to talk about this. My name is Michael Tang. I am trained as a primary care pediatrician, so I'm a board-certified primary care pediatrician, child psychiatrist, adult psychiatrist, and addiction medicine physician. And so speaking here today is, in my experience, both as a primary care pediatrician and as an integrated child psychiatrist, particularly in a federally qualified health center, which is where I was before my current role. Currently, I'm the Vice President of Integrated Care at City Block Health. And what we know from the data, and as we can see from this map, child psychiatrists are not going to fix or solve the child mental health crisis in the United States by themselves, right? Most counties have 0 child psychiatrists. There are too few of us, and we are not distributed in a way to address public health. So, through direct care, I should say. So what this means is we must be collaborative. We must have a public health approach. And we probably have to use skills that many of us did not learn in our psychiatry training process. And so that's what we're talking about today. How can we make a difference through integration? Another reason to think about integration is from a financial perspective, right? Even for those with severe mental health or substance use disorders, the majority of the spend, greater than 80%, and this is mostly an adult population, but this is true for high-risk kids as well, comes from the medical domain, right? So psychiatrists working with medical doctors has the advantage of integrated care, a more seamless patient experience for kids and families, but from a sustainability perspective, it has the further advantage of being able to access a pool of funds for scalability that otherwise wouldn't exist if child psychiatrists were working alone in mental health settings. But when you're working in a different setting, it is by nature a cross-cultural experience. And, I think this is something that I found as I transitioned from my pediatric training, and then moved into psychiatry training, is the markers of culture are very different, right? And here are just some examples. On the left, you see the traditional medical exam room. It's kind of colder, sterile. There's a computer, kind of biotechnological. Where on the right is more of a traditional child psychiatry room, right? Like for play therapy. There's toys, there's nice pictures on the wall, there's no computer, right? These are just different cultural experiences. And so part of the integrated experience is understanding the culture of those that you're working with, right? On the right represents the traditional medical experience is very team-based, right? Different roles working together, as opposed to the traditional mental health experience, which really is kind of this individual therapist with the patient, just kind of one-on-one, and the transference that takes place. All of these are really important concepts, but it's also really important to name the cultural differences. And so one of understanding the culture of the primary care setting is to understand the demands that the primary care pediatrician faces, right? So this was a study for adults, but it's just the same for kids, that for a solo practitioner, 27 hours a day would be needed to meet the recommended primary care guidelines. Now, obviously, there aren't 27 hours in a day, so it's impossible, right? It's impossible to do everything you're supposed to do as a primary care doctor. Now, if you have a team, it becomes slightly more possible, right? This study said 9 hours a day. But obviously, and we all know this as providers, and we all know this from our primary care colleagues, lots of late nights, writing notes, right? Really extending beyond the traditional workday. It has to be a team, right? And so our primary care colleagues know this, and this is where, as child psychiatrists, we can play a tremendous role, because they do have so many demands, right? You can see the immunization grid, all the recommended immunizations. It's so complex. On the far right is the bright future recommendations. There's just so much to handle in a 15 or 30-minute primary care visit without a team, and a team that can and should include child psychiatrists and child behavioral health staff. But we know there is a clear primary care advantage, right? That primary care pediatricians are well positioned to provide a lot of the mental health needs of kids and families. This is a policy statement from the American Academy of Pediatrics from 2019, and it highlights what we all know from our primary care pediatrician colleagues, is that they bring a developmental mindset, right? They are the front line in a child's care, right? Kids and families are used to seeing primary care providers for boo-boos, for vaccinations, and if necessary, for stress and emotions and depression and substance use. And so really at that front line, have that longitudinal relationship, sometimes from birth all the way through adulthood, with a family-based approach, maybe other siblings, in multiple settings, acute, routine, chronic disease, with that emphasis on prevention, there are clear benefits that our primary care colleagues can bring for which we can collaborate with. But obviously there are disadvantages, and I can say as someone, as a pediatrician, these are areas that I did not get as much training as I would have wanted, and I didn't get a chance to be exposed to until I trained as a child psychiatrist, right? But some of those knowledge gaps include clinical knowledge gaps in mental health. How do I do a triage for suicide? How do I assess someone urgently? How do I deal with psychosis or intoxication? Motivational interviewing, other brief therapies in primary care. How do I prescribe antidepressants, buprenorphine? So these are areas that the typical primary care pediatrician has a clinical gap. There are also system and practice gaps as well, right? How do we build a multidisciplinary team that includes mental health providers, right? What are the workflows to integrate? And what would be some of the billing practices needed to integrate this into a primary care practice? You know, these are different F codes, these are different CPT codes. How do I know how to use them? This, again, using this 2019 policy statement from the American Academy of Pediatrics, they present a potential vision for an integrated practice, right? Where the primary care medical team provides a lot of the support. But even in this setting, there is a clear role for child psychiatrists and for specialized child mental health providers. And this is highlighted in red, but emergency care, consultation, in kind of stepwise care. So even if the primary care providers are managing first and second line psychosocial and medication treatments for ADHD or depression or anxiety, once you get to that third step and beyond, having those mental health providers available. Obviously, for more complex care, first episode psychosis, more severe substance use disorder, these are areas in which the mental health professional can provide clinical support in addition to that practice-based support as well. But again, just to emphasize, there is clear value from the primary care provider. This was a seminal study in adults, but has been validated similarly in kids in the New England Journal of Medicine in 2006 for STAR-D, and it again emphasizes that primary care providers are just as good as psychiatrists at managing depression with structure, with the proper workflows in a stepwise process. In this case, it was an SSRI, escalating rapidly, treatment to target, switching or augmenting if there isn't a rapid response, and really getting very similar rates of remission and response as a psychiatrist would do, and not needing to hand off to the psychiatrist until more third or fourth line treatments, right? So we know there's clear benefits in dividing and conquering and leveraging the benefits of our primary care colleagues, but also augmenting and supporting as child psychiatrists. That's the clinical approach. From a practice-based approach, I'm speaking now toward some of my experiences when I was at Dimmock Community Health Center, which is a federally qualified health center in Boston, where I was for many years. And at Dimmock, we really believed that integrated care was not only workflows and co-location, it really needed to have management integration as well to reach the fullest benefits. And so in this org chart from Dimmock, we had embedded behavioral health therapists, psychiatrists, and our philosophy there was anyone caring for the same patient and the same family should have the same boss. So they reported to the clinical directors. And this was a cultural shift, right? To have a social worker or a child psychiatrist reporting to an internist or a pediatrician was a cultural shift, but had huge benefits in building a team while there was kind of a dotted line reporting across the behavioral health to a behavioral health integration director, and that was my role at the time. All of us reporting to a chief medical officer to ensuring some of that cohesion and reducing the silos that can exist. And by having the org chart show this level of integration and collaboration, it really enhanced the level of clinical care. Some of that integration played out even if you just looked at the work area. So here's a photograph of our workspace, and literally you had primary care doctors, psychiatrists, nurses, community health workers, social workers, all sitting next to each other to enable collaboration, not as I'm going to pick up the phone or send a message in the EHR or send a fax, but literally swiveling your chair so that you could take care of the same patients with your colleagues who you sat next to every single day. And we saw tremendous benefits with this approach. Our patients saw the benefit too. And so this cartoon kind of speaks to an end-to-end experience from our primary care pediatric clinic. And so we talked about how the workrooms were integrated. Here we can see, and this is the floor plan, how from a patient's perspective, things were integrated as well. So literally, there was no sign on the door that said, child mental health clinic. It only said primary care pediatrics. And they had that shared waiting room highlighted here, shared exam rooms for both medical and behavioral health purposes. And then shared offices, right? Highlighted here in blue are the medical offices, but for medical staff, but the child psychiatrists, the social workers were literally embedded into it together. With this is called the business office, but literally this is like the lunchroom where everyone is sitting together and building those relationships. So really one space from a staff perspective and from a patient's perspective. And so just to kind of walk through what a potential and a typical workflow or a patient experience was, a child and a family would check in to the same pediatric waiting room that they've been in their whole life. Maybe you go to exam room 1 and see the primary care pediatrician. And if there was a need identified, maybe the parent brought up a need or the child brought up a need, maybe a screen became positive, maybe the provider identified a need or a concern, they would literally walk down the hall. And so I think it was like 11 steps, right, down the hall to be able to have an integrated social worker and say, hey, I'm seeing this kid in room 1. Here are my concerns. Would you mind coming in? And then that person could come into exam room 1 and be introduced as, hi, can I introduce you to Colleen? This is my colleague who I sit with, who I work with. It doesn't have to be scary. It doesn't have to be, oh, this is a social worker. It really is someone else on the team, just like a nurse, who can help me think through as a primary care pediatrician how we can help you with what you just raised about stress or about not doing as well in school. And that was a warm handoff, and that could be billed as well from the behavioral health provider, so it can bring in some revenue into the practice. And then the pediatrician, the busy pediatrician, could step out and go see a patient in the following room where the social worker could then continue the conversation. That's the warm handoff on day 1. Then on day 2, maybe that warm handoff happens and they say, hey, why don't you come back tomorrow and why don't we, have a further conversation about what we started to talk about today, right? And so the kid and the family could check into the same waiting room and then go into another room in the same practice and have a behavioral health intake, a 90791, which child psychiatrists were familiar with and building with our colleagues, and do the real full intake that we'd be used to in a mental health setting, in a more traditional mental health setting. But this is, again, in a destigmatized, more integrated fashion for the patient and their family. Then maybe they come back in a week, right? Check into the same waiting room, and then be connected to a social worker in the same practice, doing therapy literally in the same primary care practice, building it as your traditional 45-minute therapy visit in a fully integrated fashion. And then, maybe a week after that, there's a say, hey, let's bring in the child psychiatrist. Maybe there's a little bit more than therapy. Let's bring in the pharmacologic assessment. And then as a child psychiatrist, we know the 90792, the typical intake, but again, in a totally different setting, literally in a traditional pediatric exam room, with the otoscope on the wall doing the intake. And then that patient family may come back a week later for the traditional follow-up. So really a totally integrated experience, including consultation. So if the social worker or the psychiatrist is talking to talking to the school or talking to some collateral in the community, again, being able to build that visit and bring in some revenue to the practice for sustainability. So I'm going to hand it over now to Dr. Sarvet to talk about the larger context, including contracting and payments.
Thank you, Michael. It's so impressive actually to notice, how profoundly different, that, practice environment is from what, most of us as child psychiatrists are used to. That I actually remember because I'm older than you are, and older than a lot of people, that when I was a kid, the pediatrician used to come to my home. And so it's a far cry from those days. In the earlier part of my career, the pediatricians were working in sort of cozy offices that felt homey, but they were, offices. And then nowadays, the pediatric primary care practices are, in much more kind of streamlined, in some ways industrialized, kinds of models. And, we talk about workflows and we talk about sort of all the different kinds of spaces that are so different. But I guess the main point, and sort of going into my material, is I want to talk about really how the business relationships are structured, between practices, because we're not collaborating anymore just with a primary care provider. We're collaborating with a primary care team in a practice because there are other people that we need to help in that team, beyond just the pediatrician or the pediatric nurse practitioner. And then, above that level, there's, the way that all these practices are connected to each other, and they have shared goals, and they're sort of working, across practices to try to meet different kinds of objectives. And I think we just really need to understand that. So an ACO, starting with that, just kind of a few things, and some of this is just definitional, in a way, but it stands for Accountable Care Organizations, and it's referred to as ACOs. That language really came from the Affordable Care Act, which was passed during the Obama administration in 2010, and what they are basically these networks of entities, that include hospitals. Sometimes there's a term physician or the physician hospital organization. That's a PHO. And ACOs are like PHOs in the sense that they could include hospitals, but they're really hospitals, practices, and other kinds of community organizations that really come together to collaborate to, as Dr. Tang said, really be able to take a public health approach to improving the health of populations. Those populations might be all the members, of a certain insurance plan in a certain region, that's covered by the ACO. It might be if it's a public kind of ACO that's really oriented towards public payers. It might be, sort of, the population is all the patients who are covered, by Medicaid, or Medicaid and Medicare. But those populations are defined in different ways, and so this is about pediatric practices being a team sport, not just teams within the practices, but teams across practices, and the purpose of them really, as specified in the Affordable Care Act, is to try to reduce the cost of healthcare for populations and increase the quality of the healthcare, and to look at outcomes and to try to work together to really improve outcomes, by addressing prevention, by addressing social determinants of health, and really trying to kind of navigate, patients to receive their care in the most appropriate setting, which is often not the hospital. So another term that you'll hear is clinically integrated network, and this is just another type of relationship, across practices, and it's really has the same goals. I think there's a lot of overlap between the principles of a clinically integrated network, and it sort of depends on the contract, and there are different aspects of the contract which could be addressed sort of collectively sort of in these relationships. So that's a term you'll hear, but it's really not that much different from what I said about an ACO. But this is the slide I want to speak to, what this is about, because as I said, it's about improving the health of populations, and it's also about changing the way that people get paid so that the incentives are aligned. That notion of that the incentives of the doctors and the providers from a business perspective really need to be oriented towards improving the health. They need to be connected to the idea that we need to improve the health of populations, improve the quality of care, and reduce the cost. And so the old-fashioned or the prior method of payment, which is referred to as fee-for-service payment, you can see easily, I think, and I can explain how that's an example of how there's not a clear alignment, between how people get paid and those values of trying to improve, the health, of a population, reduce the cost of care. Because, if you get paid for every service you provide, then in some ways you have an incentive to provide more services, regardless of whether they're really as absolutely necessary. And so you see sort of things like churn. The term churning, in fee-for-service medicine is when, sort of perhaps unscrupulous businesses, will encourage people to get care over and over again that they don't really need because it's easy to provide and it's profitable or generates sort of more revenue. And so the Affordable Care Act was really meant as the first major kind of strategy to shift that kind of idea, and to try to induce changes in the way that healthcare services are paid for, so that it's aligned with those values of really improving the health of populations and reducing costs of care. So just in a nutshell, and you'll hear more about this in sessions 5 and 6 in our program, but there's 3 kind of buckets or 3 categories of what we call value-based contracting, which is this new methodology that provides this opportunity for alignment. Capitation is a term that refers to payers paying these networks on the basis of how many members that they have, how many people are being covered. And they also kind of risk adjust, those payments, because certain populations need more healthcare services, and they try to model that. But they come up with kind of a rate, which is referred to as a per member per month rate. And then if the practices don't spend as much, money by providing as much service to patients, they potentially, can make money from that, because they're getting paid per member, and then they're sort of using the resources that they have at their disposal to provide the care. And if they do that efficiently, then they make money. Now you see that arrow at the bottom, which is network adequacy and quality measures. As you might imagine, there's a risk, in capitation that if you're an unscrupulous business, or less scrupulous, then you might start withholding care for people and withholding the care that they need because you have a financial incentive to do so. And so one of the safeguards or the guardrails, within these kinds of models is to say that to mandate that they have an adequate network, so that they have enough providers, in their network, in their ACO or whatever their clinically integrated network is, to provide the care. And they also have to monitor quality, so that they're making sure that they have sort of a quantitative measurement that's really specified by the contract about what kinds of quality goals, which really relate to the improving the health of the population. So if you try to withhold care, in these networks, then, that people need, then, the idea is that you're not going to hit those quality measures. And if you don't have enough people to provide the care that, are really available, then, you're going to, potentially, not be able to get paid, because you don't have that network adequacy. So those two issues around network adequacy and quality are essential for really protecting the population from, potentially, unscrupulous practices. Shared savings is sort of a combination, of saving money from sort of reducing the cost of healthcare below whatever that per member per month level is for the population, but it really builds in the quality measures much more, significantly, and the practices don't save; they don't get to keep all the savings. So if they spend less money for the population than they receive, then they share those savings, with the payer, in some cases, which is Medicaid. In some cases, it's an insurance company. And then those quality measures end up becoming really important for them to, sort of get, some kind of premium for the work that they're doing. And then the last category is the bundled payments, and that's a little different. It's not even on a continuum clearly with the other things, but it really is about sort of health plans or payers purchasing sort of a set of services that patients need without kind of sort of piecework, without getting paid for every little thing. So you might sort of get paid for taking care of an episode of care for someone who has an episode of congestive heart failure, for example, which involves, all kinds of things, including sometimes hospitalization. And then the payments are bundled so that if you are able to provide care for that patient in an efficient way, then you can actually, sort of have an advantage, financial advantage for that. Next slide, I'm going to shift. So these are some of the methods, that we need to plug into in these collaborative relationships. There's kind of clinical programs to improve the health of certain populations. So they might pick certain conditions that are very common and that really are very painful for the population that they're serving, and design protocols that everybody in the network, is going to use. And if we're collaborating, with those practices in that network, we kind of need to know what their, initiatives are and what their goals are, so that we can be aligned, with them. And there's also so as consultants and as collaborators, that we might get paid in different ways for what we do. And we might be able to share. There are some instances where we could share in some of the reimbursement that's more on a value-based payment. Or we might get paid just on an hourly basis, because they're purchasing some of our work and our effort to kind of help them meet their goals. Another point about this is that these clinically integrated networks and ACOs really need to have platforms to be able to kind of work together and sort of see the data for what they're doing. So they really often have shared electronic medical records, really allowing, having platforms for collaboration. So I'm going to pivot now. That's kind of the financial thing. You're going to hear more about this later in the program, I think in sessions 5 and 6. But I want to talk about sort of one of the the active ingredients or the essential ingredients in all the work that we do as collaborators, and that's really about engagement. And so the term engagement, has become used a lot, and it really sort of refers to the quality of the relationship and how rich it is, how much interaction there is. And a lot of the programs that we offer, in the collaborative space are so-called on-demand type programs where we sort of need to be called. We need to be asked, for help, in order to provide the help. There are some models that provide more outreach and proactive kinds of collaboration, but a lot of them really kind of call for and really require that the PCPs know, that they need help and requires that they ask for it. So obviously, if you have a good relationship with that PCP, it's easier for them to ask for help. And it might help motivate them. And a lot of programs we have seen, really have been suffering from a vicious cycle, so to speak, because they don't have engaged relationships. They haven't really been focusing on that. And then people stop calling, those programs because they don't, sort of know that they're going to get the help that they need. And then the programs, sort of start dying, from underutilization, so the people who are sponsoring these kinds of programs start to question whether they're really, necessary if nobody's really using them. So that's really why it's so important for sustainability and also for being able to help. So what does it look like? So some of these programs, and I've been especially involved in the child psychiatry access programs, which really involve teams of consultants, and you've heard about them before in earlier sessions. And so they pretty much, consider us to be part of their team. So when you're collaborating with a practice, if it's engaged, then they kind of feel like you are part of their practice. Practically, they might have your hotline if you have a program hotline on speed dial. They know everybody on the team by name. They know the child psychiatrists, and hopefully there aren't too many, so that it's much easier to relate to a team of collaborative consultants if there's a manageable number of them. And they also speak about how, they can't imagine working without us, which is a great sign, if we have a good relationship that, we really are indispensable. These relationships, actually, I love to talk about them because they're sort of, pretty rich, that they go beyond sometimes, just, us teaching them and helping them, with clinical, work. They develop into friendships, sometimes. And then the one exciting thing is that through collaboration, I've been able to find allies, to advocate with me at the State House for addressing different kinds of needs, of our community and our population. And so pediatricians have a very long history of advocacy as a profession. We don't have as much of a history of advocacy, but we do a lot. And obviously, ACAP is moving into a significant phase of really leaning into advocacy. But again, these are very rich relationships. So what are some of the factors? I want to go through these, and I think I'm going to go into each of these a little bit more detail, kind of before we end. But certainly, for us to have an engaged relationships, we have to be useful. And there are ways which we can be less or more useful, and we'll talk about that. We have to customize our work so that we have to, and the customization really is based on knowing, what the resources that they have at their disposal are, so that we're not making impractical, recommendations. If we say that, oh, you should, find a therapist to provide exposure response prevention for OCD, which is what we like to see, that's not going to be customized if there's no therapists in that community or even accessible through telehealth for doing that kind of work. So we really have to understand the particulars, of the resources of the practice, and we also have to understand their needs. So we have to cultivate relationships with the whole team, not just, with the providers, because, as we said, primary care has become a team sport. We have to be mindful of time, that when we're talking to the providers in the practice, we have to remind ourselves that, they have a very, sort of different kind of workflow than we do, and we need to match it. So we can't, give a 30-minute lecture on something, when they're asking a quick question. Trust, is another big feature of all relationships that are built on trust, and we can talk about that a little bit more before we end. And then lastly, the patient-parent satisfaction, that when the patient and when the parent is happy and when we can make the primary care provider look good and really sort of help their relationship, be effective by helping them address, the problems that patients and families have, then they're going to like us better too, because we're all working together on the same goal. I also, want to talk about telephone consultation, that I work in programs where the telephone consultation is the heart of the program, that's this hotline based, regional population based, kinds of programs, where people can access telephone consultation kind of in real time, whenever they need it. These phone conversations, or if you're in the practice, in person, these informal conversations in the hallway or between patients, that they really, they're referred to often as curbside consults, but they kind of are a modality which is far superior. And I know I'm aging myself a little bit by saying this, but it's far superior than text messages and inbox, sort of secure messaging, which is kind of what they often, is their default. And the nice thing about these telephone conversations, and if you can really, sort of try to have them, or these curbside hallway conversations, is that, you can teach them, you can kind of customize your conversation to the needs of this particular pediatric provider, that you start to talk about, back and forth as far as what they know, what they need to know. And if you're doing an inbox message, that they'll ask a question, but they won't sort of have a back and forth. So it's really hard to know if you're kind of hitting the sweet spot, in the sense of what they need. And then, the conversation is just much more conducive to building a relationship over time. So these are very short conversations, and but they mean a lot. And if you have a lot of them over years, before you know it, you have a friend, basically. So they're educational in nature. I think one of the principles of trying to have this engaged relationship is to make sure that you're not only answering the question, but make sure that you're actually identifying the learning need, which sometimes is different than the question. So for example, someone might say, oh, I have a patient on Prozac and they're not responding, and, whether or not, we should increase the dose or something like that. And then, if you just answer and say, oh, they might ask you, what's the dose limit, for Prozac? And then they probably, have access to that information, through other pathways easily. But, so if you just answer that question, then you're missing the opportunity to, find out if the patient is on the right medication, to find out if it's an appropriate sort of treatment. You might not have to worry about that, because if you've been talking to somebody over a period of time, you might already have confidence that they know, when to, prescribe SSRIs, and so you don't have to go into it as much. But if you ask questions surrounding the question they're asking without, being too, sort of tedious about asking too many or taking too much time, then you can really understand, more than the learning need beyond the question, which sometimes helps a lot. But don't forget to answer the question, because if you end the conversation without answering the question, then they'll be disappointed often. Don't be too long-winded. Don't use as much jargon as you might be inclined to use, because they don't have the same language that we have. Try to be mindful of what their limits are, in terms of how much they want to do. And there's a big variation in practice as far as how much pediatricians can and want to do. And then the last point is important for risk management, that if you haven't seen the patient, then don't tell the PCP what they should do as if you're kind of in charge of the care of that patient. Talk with them about what you would do, what best practices that you can inform them about, so that they can be aware of them, but make sure that they understand that the decision is theirs. Now, if you see the patient for a consult, then fine. You can make recommendations just like we all do, when we do consults, that are formal. But I'm talking here about informal consults. So each of one of these consults or conversations is an opportunity to enhance the relationship. And again, the volume and the number of them is really important because these things build up over time. Always at the end of the conversation, actually include, their friendly conversations. So you want to cultivate this positivity. So be friendly, that you can be social a little bit and sort of ask how it's going, but be aware that they might be busy. So keep moving. Don't sort of dwell on social things, but just start off with a little bit of friendliness, and positivity, and at the end of the conversation, make sure they know what to do, like what's the next step, and that they are clear about that, and also remind them that you're hoping they'll call you back again. So encourage them to call you back about the same patient, let you know how they are doing, based on what you discussed, and also to let them know that you're available for other patients too. So think about the next call towards the end of this call, to try to sort of set that up for the future. Practice level change is about, sort of different kinds of processes in their practice. So oftentimes you can consult with them, not just about patients, but about, their screening. Are they doing screening, and do they know how to, and do they have any challenges in terms of doing screening? Are they having trouble picking screening instruments? Encouraging measurement-based care. Every time I talk to a pediatrician about a patient, I ask them what measure they're using, and that actually, I get the answer. Sometimes it's none, sometimes it's, a PHQ-9 or whatever, but just asking the question every time sends a very strong message that we think it's a good idea for them to use measures to track their patients. You can talk to them about, how to group their patients in registries, talk with them about different kinds of system level care navigation principles, which are good for them to know, and they definitely need to know. So all of these things are kind of practice level change that you can help with as a collaborator. So the usefulness of encounters is extremely important. We talk about a three-legged stool for collaborative care programs, in the sense that in order for them to be practical, that they don't just need the answer to their questions and to need to know, what to do, but they often need help finding resources, which is why a lot of our programs include resource coordination. And then in our program, I would say every time someone asks a question about, at least 20%, and it's gone up to 30 and 40 as the program has matured, that we don't know what to say because it's too complicated, and we don't have enough history, and we don't think the pediatrician is able to get the history that they need. And in those cases, we should see the patient ourselves and offer to. And so I feel like the best, engaged relationships, in these models include a pathway for us to actually see the patient and do a direct formal consult, not just telephone consultation. And that's why if any one of those legs of this particular model is not present, then the programs don't get utilized very well because the people aren't as engaged. I talked about customization. We talked about ACOs. We talked about the importance of the friendliness and the, kind of the non-technical, aspects of the relationship. Talked about the need for the conversations to be efficient. Trust. One of the ways that we promote trust, in this kind of work is that we make sure that we're providing consistent principles, because we're teaching over time and multiple, bite-sized chunks, as we say. And if we start giving different, advice, for similar things, then people get confused and frustrated. So reducing variability, requires us, in programs, and when we have more than one child psychiatrist, to work together to make sure that we're on the same page in terms of consensus, practice guidelines. And we have developed our own practice guidelines in Massachusetts that we use that really help us to be consistent. There's a lot of promises when you talk about, patients with primary care providers. Then oftentimes you say, oh, well, I'm going to send you this, or I'm going to follow up with this patient and see them, and then I'll get back to you. And just, make sure that you kind of sweat the details as far as kind of circling back and doing all the things that you say you're going to do, because nothing, in my experience, frustrates pediatric primary care providers more than saying you're going to do something and then forgetting about it, and then having them call you 2 months later to say that it never happened, and that's not good. And one of the most common examples of that is that when we say that we're going to do a direct formal consult, and we say that our staff are going to contact the patient to schedule it, the patient might come back to the primary care provider a couple months later and say, I never got called. And then they'll be mad. The primary care provider will be a little bit annoyed with us if we haven't, already told them, that we tried to call the patient, 4 or 5 times, and the patient never returned our calls. And so if they know that when the patient calls and says, that they never got called, then they'll know that, this is not, our falling down on the job. And so it's important just to kind of circle back and let them know when things are not going as planned in what we kind of agreed to do. So the trust is critically important. And then the last principle of engagement is the patient and parent satisfaction. And we talked about this before, but these programs, these collaborative programs, aren't always considered to be so-called consumer-facing programs, where we're sort of focused on trying to satisfy, the needs directly, of patients and parents, that we're doing that through the primary care provider. But there is some customer service with patients and parents in the program, because we're calling them to set up evaluations. We're providing resources for them. We're helping them find resources, and all those contacts and touch points that we have in these programs with patients, I think it's really important for us to maintain a good relationship with them, not just with the provider, but with the patients, which really refers to what we call service quality of the programs. And that's another important thing. So the last thing that I want to show you is an example of one of our clinical practice guidelines for the Massachusetts program. As you can see, it starts with screening at the visit. It goes into assessment. It has different arms, for how to, based on the severity, and then it moves into medication recommendations. The guidelines that we have are focused on medical management, but I also want to end with the point that one of the things that we really sort of feel strongly about in these programs is to try to prevent pediatricians from leaning too much on medications, because that's kind of the easiest and default thing that doctors do, that we prescribe, medicines. But the pediatricians, one of their learning needs, I would say one of the most important learning needs that I've encountered with pediatricians, is to understand that treating psychiatric illnesses is not just about what medication do you prescribe. It's kind of a whole sort of biopsychosocial approach, which child psychiatrists know, but the pediatricians don't always know. So oftentimes, we really talk more about non-medication oriented treatment planning than we do about how to prescribe one medication or another. And so I think that's my last slide. And thank you so much for your attention, and thank you, Dr. Tang, for your collaboration.